Now we'll be discussing about the congenital condition of larynx. The most common condition which we encounter is the laryngomalacia or the congenital laryngeal stridor. And it is the most congenital anomaly of the most common congenital anomaly of the larynx, which is leading to stridor, and it is the most common cause of stridor in infants. So clinical features, in the clinical features the patient will be having a inspiratory stridor, and basically it is because of the weakness of the supraglottic part. It is because of the supraglottic part of larynx. So remember, in stridor which we have read, that is the patient will be having any airway obstruction in the pharynx or the supraglottic part of the larynx, the patient will be having a stridor. So clinical feature will be patient is having a inspiratory stridor. Patient is basically having a inspiratory stridor, and what will be the inspiratory stridor looks like? So you can see that this is a patient who is having a inspiratory stridor. The stridor, it usually begins, it starts in the first week of the life. Basically it is aggravated on crying and when the patient is lying supine. So when the patient is lying supine, the supraglottic part, it falls, it comes in the airway. So a baby who is crying or lying in a supine position, this stridor will be seen. But if this stridor, it disappears when we make the baby prone, so this is a characteristic feature of the stridor of the laryngomalacia. So the cry of the baby will be normal. The cry of the baby is normal because the vocal cords are normal, and basically this condition, it occurs as a result of the floppy portion of the larynx that has not yet developed, and the strength which is not developed to provide the rigid support to the airway. And sometimes in this condition we also see the cyanosis. Now what will be the finding on direct laryngoscopy? If we take a laryngoscope and if we try to do a laryngoscopy, we will see a omega shaped epiglottis. This is the omega shaped epiglottis. There will be also a floppy, tall and thin airy epiglottic fold. You can see there will be they are thin airy epiglottic fold, and there will be prominent arytenoid. So these three features you can see in the image also. These three features are the characteristic of the laryngomalacia. And in most patients of the laryngomalacia, they are self-limiting, that is they don't require any treatment. That we should give reassurance to the parents that whatever it may be, that this, as the larynx, it attains the strength and the maturity of the laryngeal cartilage, this is a self-limiting condition, and by mostly by 2 years of age of the patient, this condition, it disappears, and you should try making a baby sleep in the prone position. So reassurance is very important. Another factor is that we must tell the patient about the LPR, that is PPI must be given to the kids. And the third part is that if we are encountering any kind of upper respiratory tract infection, we should not hesitate on starting the antibiotic therapy to the patient, because it may otherwise it may lead to an acute airway emergency. Now the next congenital condition is the congenital subglottic stenosis, and it is the second most common congenital anomaly of larynx leading to stridor. Now what is it, how we make the diagnosis of the subglottic stenosis? If the subglottic diameter of a full term neonate is less than 4 millimeter, or if in a premature neonate the diameter of subglottic diameter is less than 3 millimeter, then we can say that this is a congenital subglottic stenosis. Then congenital subglottic stenosis, it can be acquired also. So it can be congenital and it can be acquired also. Now there is a grading which is done by Meyer and Cotton, and they have classified basically into 4 grades. The grade 1, it starts from no obstruction to 50% of the obstruction. So the grade 1 is from 0% to 50% obstruction is grade 1, and grade 2 is when it is from 51% to 70%. Grade 3 is 71% to 99%, and grade 4 is when there is no detectable lumen. So very important, just to revise, Meyer Cotton grading is basically classified into 4 grades. grade 1, 2, 3 and 4. Grade 1 is 0 to 50, grade 2 is from 51 to 70, grade 3 is from 71 to 99 and grade 4 is when there is no detectable lumen. So how will we treat such patient? So the treatment of such patient basically is in the grade 1 and grade 2, the treatment is the same. We will be doing a conservative management of the such patient, will be going for endoscopic dilatation or for the laser excision. But the problem arises in the grade 3 and the grade 4 lesion. The grade 4 is not, it is not, the patient will die if it is not treated early. Whereas grade 3, the treatment, it consists of tracheostomy. The first and foremost is that we must do tracheostomy and we must do a laryngotracheal resection as well as the cricotracheal resection. Even in grade 4, we must do these things only, tracheostomy with laryngotracheal resection and the cricotracheal resection. Now, LTR stands for laryngotracheal resection and CTR is the cricotracheal resection. Now, what we are doing in a laryngotracheal resection is that how we are removing this, the stenosis part is that we are cutting through the anterior lamina of the cricoid cartilage, we are opening it, we are removing the obstruction and we are putting a graft in between the anterior lamina and the posterior lamina of the cricoid cartilage, and we are putting a Montgomery T tube in between which will act as a scaffolding. Whereas in cricotracheal resection, we are cutting the stenotic part of the larynx, and the cricoid area, we are removing it and we are doing end-to-end anastomosis. So the result of cricotracheal resection, they are much more higher, the success rate of cricotracheal resection are much more higher as compared to the laryngotracheal resection. Now the next condition is the laryngeal web. It is also a congenital condition and it is basically because of the incomplete recanalization of laryngotracheal groove. Like you can see here, this is the laryngeal web. The most common site of laryngeal web is the glottic part and 90% of them are located anteriorly. Like in this condition, this is the anterior, this is the posterior. So 90% are located anteriorly. The child presents with a weak cry and aphonia since birth. Why the child will present with a weak cry and aphonia? Because the vocal cords, the primary function apart from respiration, the function of vocal cords is to phonate also. So the child will present with weak cry and the aphonia since birth. The treatment of laryngeal web, it consists of CO2 laser division of the web and placement of a silastic keel. So in case of subglottic stenosis, we were putting a Montgomery T tube, and in case of laryngeal web, we are doing a CO2 laser division. Basically, it is a evaporization of the laryngeal web followed by placement of the silastic keel is basically placed in between the vocal cords at the anterior commissure. So just remember for the sake of it that there is a classification which can be asked in the exam. Just remember the name of it, that is a Cohen's classification, which is used for the classification of the grading. It is basically a grading of the laryngeal web. Just to revise about the laryngeal web, the laryngeal web is basically because of the incomplete recanalization of the laryngotracheal groove. The most common part of the larynx which is affected is the glottic, and 90% of them, they are lying anteriorly. The child presents with a weak cry and aphonia since birth, and severe cases they may have stridor. The treatment is CO2 laser division of the web, placement of the silastic keel, and the classification which is used to grade laryngeal web is the Cohen's classification.